Hello, friends. Today we'll be going into greater detail about the peripheral nervous system. So, the peripheral nervous system is composed of a lot of ganglia, and those are just aggregations of neuronal cell bodies. And then the satellite cells within are the supporting cells, so they will convey nutrients or get rid of metabolic waste. The ganglia are surrounded by loose fibrocollagenous connective tissue and a capsule made out of denser connective tissue. The dorsal root ganglia and the cranial nerve ganglia are somatosensory ganglia. That means they receive the afferent impulses from the skeletal muscle and the viscera. The autonomic ganglia are the cell bodies of the postganglionic neurons, and the sympathetic paravertebral ganglia are the sympathetic trunks, and those can be pre-aortic or pre-vertebral. And what does that mean? The sympathetic, secondary neurons are just along the vertebral column, while the parasympathetic ganglia are smaller than the sympathetic ganglia, and they're near the effector organs, and inside those organs they're called the intramural ganglia. So those are going to be associated with, here we go, the postganglionic axon, and then it communicates with the cell body or the communicans in reflexes. The somatic sensory ganglia are pseudo-unipolar, and the autonomic ganglia are going to be multipolar. The bipolar ganglions will get synapses from the preganglionic neurons, and those really exist mostly in the eye or the vestibulocochlear system. Satellite cells, they surround the neuronal cell body, and these don't have any synapses. Instead, they have a lot of receptors kind of arranged irregularly in the cell membrane. These are all seen with the Clover-Barrera stain, also known as the Luxol-Fast stain. And that kind of shows, here's the myelin, the connective tissue, and all of the glial cells. This connective tissue of the capsule is going to be continuous with the connective tissue of the perineum and the epineurium of the peripheral nerves, and we'll go through that in the next slide. As you can see here, bipolar is going to just go through the axon or dendrite, get integrated, and then continue the signal. Unipolar just goes through without reaching the soma. And then the multipolar will just be able to receive information for many other axons. So the nerves are sheathed by the Schwann cells, or they're also known as neurolemnocytes. And those Schwann cells can have any combination of axons. So that can have axons from multipolar neurons or bipolar neurons or neurons from several different structures. And the cell bodies of the peripheral nervous system, they lie in the somatic sensory ganglia or the autonomic ganglia along with the central nervous system. The axons are going to be grouped into fascicles to make the nerves, and they're all surrounded by the endoneurium, individually, and then those fascicles are surrounded by the perineurium, which is a collagenous tissue, also has some epithelial cells in it. So this is the epineurium, here's the perineurium, and then these would be septa running through the tissue. The peripheral nervous system is also vascularized by large vessels in the compartment, and they lie either between the perineum and the epineurium, and there's going to be a large capillary network in the endoneurium. So let's just go through this again. So the Nissl bodies will provide the molecules and the organic substances used for protein synthesis, And around this white stuff, that's going to be the myelin. This is going to be the gray matter here. Here's the white matter, as you can see, with a lot more like, white substances, which is going to be the myelin. Here are the axons. Neuropil, that's the meshwork that really supports and protects the neurons. Unmyelinated nerves, as you can see here, like, remember the other picture that I showed that had like a nice white surrounding it? This one does not, so this is going to be an unmyelinated nerve. Those are going to be the smallest fibers. The postganglionic axons of the autonomic nervous system and the pain fibers are unmyelinated nerves, technically, but they are partially enveloped in like one Schwann cell. The Schwann cells that like surround them, they don't have many layered wrappings, and they're generally just like restricted to a certain region. So the axons will become invaginated into the Schwann cell and embedded into their channels, as you can see here. And the Schwann cells will only extend locally. Like I said, they're going to be restricted. And then at termination, once it reaches the organ destination, the ensheathment will continue by like another Schwann cell. There's not going to be any nodes of Ranvier. And the mesoaxon that forms inside the Schwann cell is going to be a zone of apposition, which just means that it's going to expose the cell to interstitial fluid and allow an exchange of ions. So myelinated nerves are made out of the Schwann cells, and inside the Schwann cell there's a cytoplasm and these invaginations called the mesoaxons. And they rotate and spiral around an axon, and the major dense lines, as you can see here, I think it's the purple lines, they're the fused cytoplasm surface of the Schwann cell membrane, and then the Schmidt-Lantermann clefts, like you can see here in between the major lines, will allow the transient movement of material. And then the intraperiod lines are going to be on the outermost layer. And the internodal period is the length of the axon covered by one Schwann cell, and those vary in length due to axon diameter. So the wider the axon diameter is, like, the shorter the internodal period. And then the nodes of Ranvier allow the saltatory conduction, which is the electrical signal kind of like skipping over the myelinated part and only depolarizing at the nodes, which makes the process of like, depolarization and impulse like much faster. And those have a lot of voltage gated sodium channels. And as you can see here, this is the peripheral nerve. Here are the Schwann cell nuclei, and see how they kind of like surround the nerve fibers. And here's going to be the nerve fibers, as you can see here. And all of them are grouped in these fascicles. The myelin sheath is made out of a phospholipid complex, that's made by the Schwann cells, and there's a differentiation between the peripheral nervous system and the central nervous system because the myelin sheath is made out of the oligodendrocytes in the central nervous system. And the myelination process occurs really similar to the peripheral nervous system. One oligodendrocyte will make the myelin sheath for a bunch of axons, about like 50 to 60 axons actually. And the role of the myelin sheath is to insulate the axon, help with the regeneration of the injured axon, and form regeneration tubes. Those regeneration tubes kind of form kind of like railroad tracks, really. So it guides the path of the axonal growth and the myelin sheath. So myelination occurs first in the second trimester, and it's really the most active in the first year, and it goes on up to like 10 years. So this is why traumatic brain injuries are very concerning from ages like 1 to 10. And by traumatic brain injuries, of course, no child really should be, bonking their head in hard surfaces, but, children are children, they're going to do it regardless. But like a simple, like crash into the wall isn't really going to hurt the child. But if the child has fallen for a height or has been hit by a car or, domestic violence, if any sort of concussion has occurred, this can form a lot of damage, really. And there is plasticity because the myelin sheath undergoes remodeling even throughout like adult life. Of course, it's going to be a lot better when we are young, but it's still not advised. There's a lot of literature out there kind of showing that psychopathic behaviors can occur because of traumatic brain injuries in early childhood. So, yeah, don't let your kids fall. So here are the mesoaxons once again, the invaginations. This would be the unmyelinated fibers. Here's going to be the cell body. Schwann cell surrounds everything, and look how it kind of encirculates. Nodes would be these blank places, or where the Schwann cell ends. And here is a nice a picture of a myelin sheath in I think this is a TEM image. So there are several diseases that affect both the central and peripheral nervous system, and that is the demyelinating disease. Those can be caused by inflammation, viral infections, metabolic problems, compression, hypoxia. In the central nervous system, the multiple sclerosis is the most common acquired demyelinating disease. It involves some autoimmune processes, and those can form lesions in the skin, functional deficits, visual changes, vertigo, sudden unilateral blindness is one of like the hallmarks, along with like decreased muscular strength and aphasia or dysphagia. So polyneuropathies are really in like the peripheral nervous system myelination disorders. The Charcot-Marie tooth disease, it affects the extremities, and it can cause the foot drop, numbness in the extremities, and it's really it's really characterized by these clawed feet, which is called pes cavis, where the arch is very high and the toes are almost like crossed, which are like hammer toes. As you can see here, this toe goes under, and then the hands would be clawed hands. This is a slow progression, and unfortunately it's somewhat treatable, but it's not curable, and it's not fatal. So that's one good thing, I suppose, but it is a debilitating disease. So peripheral nervous systems can regenerate after an injury as long as the cell body is not affected. So the cell body, if there's like a change, the cell body can swell this is how it regenerates. First, it begins with changes in the cell body. The cell body will swell, and then the nucleus will become eccentric, and it will start moving more towards like the periphery of the cell. The nissl bodies will go through chromatolysis, and those will get smaller. And then there's going to be synaptic stripping, where the synaptic terminals will be withdrawn, and the Schwann cells will replace the dendrites. And the morphological changes are actually more common in the motor than the sensory neurons, so it's a little bit I don't want to say easier, but it's a little bit more common for the motor to heal a lot better than the sensory neurons. And there's going to be some anterograde or Wallerian degeneration in the endoneurium, and then the axon will become irregularly swollen, and then it will degenerate along the myelin sheath. So the injury will occur, like let's say right here, and then Wallerian degeneration will occur. So anterograde, it goes back to the cell body, and then the macrophages will come and clean up the debris. And here are the dendrites forming. The Schwann cells will proliferate, and these will kind of replace the dendrites. And then there's going to be the myelin reforming, and then the muscle will regenerate as long as the patient undergoes physical therapy. So an unsuccessful nerve regeneration is when the axon will become irregularly swollen, and then it will degenerate and not make that linkage. The endoneurial tubes will be cleaned, and then they will persist, so that will kind of like make the tracks to like reform the axon. And the axon regeneration really depends on the presence of the endoneurium tubes and the Schwann cells. And as I said before, the Schwann cells will proliferate along the degenerated axon following the endoneurial sheath, and then they fill space in the basal lamina of the endoneurial tube. In the proximal stump, and then to the next like node of NBA, and then the kind of end, and then it goes to the distal stump to the end organs. So the fine filaments from both stumps will grow along the cleft, like the injury. They enter the closest end of each endoneurial tube, and then the laminin and cell adhesion proteins will like link them together, and that will stimulate the axonal growth. So regeneration can take 3 to 6 months depending on how bad the injury is and where the injury has occurred and what the injury has occurred to. And in clinical practice, physicians say it occurs around 1.5 millimeters per day. And then a neuroma occurs when an axon will like sprout abnormally and form like a nerve swelling. The myelin sheath formation start at the site of the original lesion, and then it extends, but then it might get too large, and then pressure and movement will inflame it, and it will cause a lot of pain that radiates to the toes. The Morton neuroma is a plantar interdigital neuroma, and it's the most common one in the PNS. So here is a neuroma. As you can see, it's pretty big, lots of layers. So neuropraxia occurs when there's excessive pressure on the nerve, and that will cause a conduction block. So the connective tissue sheaths are going to be intact, the structures are preserved, and it takes about 3 to 6 weeks for it to regenerate. And axonautomesis occurs during the crush injuries or traction or compression injuries, and that's when the axonal and the endoneurial tissues are going to be divided, and the perineurium and the epineurium are going to be intact, and this will take many months to regenerate. And by many months, it's going to depend on the person. Like I said, it could be 6 months, or it could be 2 years. And then neurodemesis is the worst. This is the complete disruption of the axon and all of the connective tissue sheaths. The nerve itself is going to be divided, and this absolutely needs surgery. Prognosis varies. Sometimes the surgery is successful and the person regains full use and sensation. Sometimes it's partially successful. The person might have full use, but there's going to be some numbness. Like I said, it's going to be dependent on where it was damaged and to whom it was damaged. A younger person will regrow their nerves a lot better than somebody who is older. Okay, so CNS injury, no doubt, is worse than PNS injury. And an injury to a nerve trunk will have a very low chance of recovery. And those neuronal injuries will cause irreversible and devastating disabilities. And those involve the degeneration of the axon and the myelin sheath. the axon degeneration, there is no growth because there are no endoneurial tubes in the central nervous system. Instead, the astrocytes will make a fibrocytic scar, and that may, bring back some functions, but in general, it does not. The fibrocytic scar kind of serves to just put a stop sign on the nerve impulse. Neuroglial cells will make the nerve growth inhibitory factor, and the low amounts of laminin and myelin will inhibit the axonal growth, while high amounts will stimulate it. Intergrade transneurodegeneration is when the degeneration will transmit to other neurons that serve the same function. So this is clearly quite terrible, because that can cause some not just localized dysfunction. It can cause some general dysfunction. So here are the steps. First, there's the injury to the spinal cord, and then there's going to be the transmission of the injury signals, and that will activate the endothelial cells, and then there's going to be an acute response where cytokines and chemokines are going to be released, and then the leukocytes will migrate, and the leukocyte-mediated damage to the secondary organs, and then the liver will produce the limiting late phase reactants. Okay, that's it for now. Thank you for your attention, and good luck studying.